thank you everyone for coming another case discussion series, and we are honored to host Dr. Phil Scheinberg from head of division of hematology and from São Paulo, Brazil, and he's been a great supporter of aplastic anemia partnerships and consortiums and studies since 2005. Can I say that?
It's 2001, 2002.
2001. Okay,
Yeah,
2001,
it's
2001.
been
Okay.
20 years, over 20 years.
Okay. Oh, okay, great. So we'll start with the first case. This is a 55-year-old female patient with 3 months of aplastic anemia diagnosis without any AA treatment, admitted with severe mucormycosis infection complicated by septic shock. She was started on vanxosin, amphotericin, and valacyclovir. And then 10 days after initial presentation, patient overall condition improved, although continued to be a transfusion dependent with red and platelet and very slow, very low ANC, less than 200. Repeat bone marrow biopsy confirmed her initial diagnosis of acquired very severe aplastic anemia with very low PNH clone, less than 0.1% granulocyte, unremarkable DEB and telomere flow fish panel for inherited panel. So the first question is going to be, what other testings should be part of the AA diagnosis for this particular patient?
So there's two things when you evaluate a patient like this. So they have pancytopenia. Usually the onset of pancytopenia in patients with AA or severe AA is often acute, rapid onset. And you need to make sure that you have the right diagnosis. So you do a bone marrow biopsy, which is very, very important. And I say that because when I came to Brazil, people were not too keen in doing a lot of biopsies of the bone marrow. But if you want to look at cellularity, you need to do bone marrow biopsies, obviously with an aspirate smear to look at dysplastic findings, especially in somebody who's 55, and cytogenetics and flow cytometry. So I assume this was done here. The diagnosis was made. The counts are very low. There is this diagnosis of aplastic anemia, which is a diagnosis of exclusion. So from a diagnosis perspective, looks like things are going in this direction. Now, when you have a young child or an older adult who is diagnosed with aplastic anemia, you have to worry about a few things. So if you're in the lower age spectrum, you have to worry about telomeropathies, Fanconi, and ribosomopathies. And the way you kind of look at these things, you do the DEB testing, which when I was at the NH, we did it up to the age of 40. Telomere length is also something that can give you some insight into of some underlying genetic defect in the telomerase genes. But in the older population, you have to worry about MDS. So in this patient, obviously cytogenetics needs to be done. Not sure if it's been reported, but were there cytogenetics, Taha?
No, I did not report it, just to elaborate on cytogenetic benefit.
Okay, so cytogenetics is very important because it can give you an indication that you might have a clonal process. Now, hematopoiesis and aplastic anemia. Hematopoiesis and aplastic anemia can be clonal, but if you have a cytogenetic abnormality that is associated with MDS, you might want to think, especially if there's dysplasia, you may want to think about a underlying dysplastic syndrome process. It can be difficult in some patients. But we would have to have exuberant dysplastic findings with consistent cytogenetic abnormalities. Sometimes flow cytometry can help to look at dysplasia given apparent markers that are expressed on the surface of progenitor cells in the bone marrow. So it can be corrupt, it could be contributory in that sense. The one test that is not, has not been established to be useful is the genome myeloid gene panel, somatic testing. It's been done, people do it, but it's not something that has been shown to be terribly helpful in isolation, especially. Now, if there's a lot of questions about what the diagnosis is based on these other more common routine testing, I can see why somebody might want to add a somatic gene panel to help and differentiate the diagnosis. But that's not been well established, Taha. So, and it can be more confusing at times. But so to wrap this up, cytogenetics, 20 metaphases. In children, oftentimes fish can be helpful. The pediatricians like to order fish. That has not been well established. in terms of trying to establish a differential diagnosis. And flow cytometry with an aspirate would be the more routine things that would be missing here. And the questionable testing would be the myeloid somatic gene panel, which could be helpful or it could be actually confusing depending on the results.
Yeah, I have two questions following this comment. So the cytogenetic, sorry, the next generation sequencing sometimes can be very confusing. If it is really about certain percentage of VAF, they may be diagnosed this patient as CCAS or some sort of evolving MDS other than aplastic anemia. Sometimes it will delay the treatment of aplastic anemia. That is something that I wanted to kind of put in
And
your.
that's the problem. I mean, what you just highlighted is the problem because it's not uncommon for patients with aplastic anemia to have some of these myeloid gene neoplasm mutations and with low VAFs, usually less than 10%, 2%, 1%, 3%. So, and what do you do with that information in isolation? So I think that we're not ready yet to do this systematically. It can be confusing and it could even delay diagnosis and therapy, which is the worst scenario that you would have in this patient who requires immediate attention and immediate therapy. So I agree with you. And I think in very selected specific scenarios, it could be helpful. But I think for most people, it could be confusing and it could actually take you away from the main focus of the diagnosis. So we don't usually get it routinely in our center unless we're suspecting that there might be some myeloid neoplasm. Now, having said that, we do it in the context of the research setting. We don't do it in the context of just a routine care setting because we want to learn and gather this information. But I have been very hesitant to use that information in isolation, especially if everything is pointing to a severe aplastic anemia diagnosis with no dysplasia, no karyotype abnormalities. I would be very hesitant just on the myeloid gene panel and NGS change that course of diagnosis and management.
And then one more question before next question. So how about the T cell rearrangement PCR testing?
So we did a lot of that when I was at the NIH. There was a lot of TCR gene rearrangement studies, and we noticed that very rarely that they were contributory or added much to what we learned from the other tests that we mentioned here. Obviously, when you do TCR gene rearrangement testing for clonality, you're thinking about LGL. That usually happens in the setting of neutropenia or anemia with a PRCA type of picture. Usually does not give you a hypocellular marrow, usually does not give you pancytopenia. And it's something that is part of the bone marrow failure syndromes. But in the right clinical context, you would think about LGL. But in this setting with severe pancytopenia, hypocellular marrow for age, I think you can have these LGL clones in aplastic anemia. So I don't think that would change our diagnosis. What we did for a number of years was to do spectrotyping and TCR sequencing to test for clonality to see if this patient had an immune aplastic anemia or if they were treated with ATG cyclosporin, and if they remained to have a clone TCR by TCR gene rearrangement, if that was a patient who was a higher likelihood of relapse, or if there was still an ongoing immune attack. But that didn't turn to pan out when we did that in more patients systematically. So I think it has limited value when you're looking at a diagnosis of severe aplastic anemia. It can be ordered. We used to order that routinely at the NIH, but I looked at our data. We rarely saw it being helpful, so we stopped doing that routinely. Now, if there's a suspicion for LGL, and I have a patient right now admitted at her center who's being treated for LGL, yes, but that's a different clinical scenario.
Okay, gotcha. Okay, again, the same case. How do you approach very severe aplastic anemia patient if they present with a fungal infection, especially like this patient, severe fungemia?
This is a very practical question, and it's very unusual for a patient with severe aplastic anemia to present with mucormycosis. It's not something we see routinely. So when we looked at lots of data, looking at infectious complications over a course of since 1989 till 2009 or 2005, I don't remember now, over 25 years, with the main causes of infection in aplastic anemia, severe aplastic anemia, that were deadly were aspergillus. And that was still, and we updated that data to include more recent data from 2000 to 2010. It was still aspergillus. Mucormycosis can be observed. It's unusual, especially on presentation, but it can happen. And it can be a very difficult fungus to treat because they might not respond very well to amphotericin-based regimens. You might require surgery to get rid of the fungus. But in this scenario, if you have a patient with severe neutropenia, you could then treat the mucormycosis as well as you possibly can. Once you have this under some control, I would go ahead and treat the patient, because the longer this patient remains with neutrophils that are very low, the harder it's going to be for this patient to overcome infections like this. Now, the one thing we did at the end, we do actually, we started at the NIH and we published this, about 30 patients. We did granulocyte transfusions in a number of patients with very severe fungal infections that were not responding well to the optimal antifungal therapy. So this is something that could be done if you're running out of options and the patient is not doing well with your antifungal surgery. If you cannot operate, especially with mucormycosis, then granulocyte transfusions would be something that I would consider. It can be done relatively safely. I mean, it's not something that's done routinely, but in big centers, I think that can be done. And we do it here. We published 30 patients when I was at the NIH, and it has quite a good success record. I mean, if you do it in the right setting. Obviously, if the patient is too far out, too far gone, then the granulocytes are not going to be able to do miracles. But yes, we used to employ them relatively early once we, saw that this is an infection that would really compromise the patient's ability to stay alive and to initiate immunosuppressive therapy.
Okay. So, how do you, can you a little bit allude on antimicrobial regimens before ATG administration for this like severe or very severe patient without active infection? Let's say the patient diagnosed, you are waiting for some time for the ATG administration. Do you normally routinely start them on antimicrobials?
See, that is something, Taha, that is not established. Actually, it's not well established. It's established. So there's no specific literature on how to prophylaxis or preemptively. Obviously, if you have somebody with an infection, you treat. But before an infection, if you do something preemptively or primary prophylaxis or second, so it's not well established. And you see centers and places that have their own practices. I participated in the past in advisory boards, and people with aplastic anemia or bone marrow failure. And that they ask, well, how many of you do this? How many do HSV prophylaxis? How many of you do antibacterial prophylaxis? And people raise their hand. How many use antibacterial and antifungal? And some people raise their hand. And so, how many use Bactrim or PCP or pneumocystis? So it was all inconsistent. Everybody did something different. There was no consensus. So that told you that there's no data. Now, we don't usually give a lot of anything, to be honest. And this is something I brought with me from the NIH. So we didn't usually give primary prophylaxis for anything, for fungus or for bacteria. And even for fungal infections, some people give fluconazole, some people give voriconazole, some people give posaconazole. And I don't usually give it as primary prophylaxis on somebody who has never had absolutely no nodules in there, no evidence of fever, no evidence of anything. We don't do that for bacteria either, unless they have a fever or something, and then we obviously follow the neutropenic fever route. And if you do a CAT scan, and then you might find a nodule, and then you might want to give them some antifungals. But short of any of these informations, we wouldn't do anything routinely for. We wouldn't give primary prophylaxis for bacteria with quinolones or something else, neither for antifungals. Now, if there's a fever and we don't have an origin and it's not well established, and you find something funny in the lungs, then that's different. Then you might want to change and give something. But short of that, I don't usually give it routinely. But I understand that some people do it differently, that they give antifungal prophylaxis or they give antibacterial, or sometimes even both. And I haven't done it. And And it has served me relatively well. I mean, I haven't had problems, with this approach. So no, we don't. I don't usually give these things routinely before starting EKG or once a patient is being diagnosed with aplastic anemia.
Okay, got you. So you touch base on this granulocyte transfusion. The patient that I'm presenting now is a real patient we encountered 7 months ago or so, and she was diagnosed at outside facility, came to us because of this diagnosis. Initially was thought to she received some ATG at Mexico, but that was not real. And later on, we repeated the biopsy, confirmed the diagnosis, and she had a mucormycosis. And we did the granulocyte transfusion, granulocyte infusion. As you alluded, some benefit has shown on these people. Do you want to add anything to granulocyte infusion?
Yeah, I'm a believer in granulocyte transfusions in this patient population. Remember, this is probably worse than leukemia in terms of neutropenia, right? You have a patient with leukemia, you give them induction chemotherapy, and after 4 weeks, 5 weeks, they recover their neutrophil counts. In this patient population, they don't recover anything. They remain severely pancytopenic, and you don't have any periods of neutrophil recovery. So, and if they have an infection, serious, like there's two serious infections here, um, septic shock and mucormycosis. Now, when you look at the granulocyte transfusion literature, there's really no well-established consensus of when you should give granulocytes to patients. But and there are prospective randomized trials, few of them, which have not shown much of a benefit. But I think there was a problem in the design of these trials, to be honest with you, and who to give it to. When we did our experience at the NIH, we actually had a very good outcome for these patients, not in all of them, but in the majority, especially if their neutrophil count went above 1,000 being transfused. So we used to give it three, Monday, Tuesday, Wednesday, like, 3 consecutive days. And if their neutrophil count went above 1,000, even for a period of time, we saw that those patients did better. So I think so. If somebody, so there's no consensus on when to give granulocyte transfusions. But having said that, what is quote unquote generally accepted would be that if you have a patient like this with severe neutropenia and with no prospect of this neutrophil count recovering, at least in the next week or two, that if somebody has a fungal infection, a serious fungal infection that is not responding to proper, adequate antifungal therapy, and this patient is going to die. So granulocytes, I think, play a huge role in controlling this infection, helping in controlling this infection, and giving more time for this marrow to recover. Now, that's something that I think very few people will argue with. Now, for bacteria, it's a little less clear, but if you have somebody with severe sepsis that is not responding well to antibiotics because there's a pattern of resistance, it's very hard to treat, or if they're getting adequate therapy, but they're just not recovering from the infection with the antibiotics, I think at that scenario, granulocytes would be reasonable to consider. I think most people are more comfortable with giving it for fungal infections, but I've used it also for very difficult to treat bacterial infections. In this patient, I would not hesitate to give granulocyte transfusions because this patient has two serious infections, especially the fungal infection, which this patient is not going to recover without recovery of neutrophils.
Okay. Yeah, I agree. Thank you. So when do you, I mean, we touch base on this. When do you delay the ATG administration or holding, especially with like this severe or very severe patient? So do you want to add anything else, what you said?
Yes, I think this is a major question, Taha. Let me tell you why. Because we see a lot of patients here in my center, or I see a lot of patients as second opinion. Like I saw a patient this morning. It was 7 o'clock my time, and it was a patient who is in the hospital. The patient has fever, has infection. It just happened a few hours ago. I was talking to the family, and the patient is admitted, getting transfusions, getting antibiotics, and they're waiting to give the ATG. And the reason is because the patient has a little bit of fever, has a little bit of this, a little bit of that, no fungal infection, no anything. They're just waiting. And if you have an established infection and you have that infection under control, That is, you've identified a pathogen and you're giving the proper antibiotics, or you have a antibiogram that you can have the resistance. You're treating this patient, and the patient's doing better. The fevers are going away, but you haven't cleared the infection yet. That is the proper time to give ATG. You don't need to have a completely resolved infection in order to give horse ATG, especially horse ATG. For rabbit, it would be more problematic. But for horse ATG, which is only a modest immunosuppressant, you don't need to have an eradication of the infection before thinking about giving a horse ATG, because then you're going to lose a lot of time. And these patients are not going to get better without neutrophil count recovery. So that is a critical thing, So once you have this under control, got them on the proper antibiotics, they're stable, either for bacteria or for fungus. You just go ahead and give horse ATG, cyclosporin, and ultramapag, the triple therapy. I would not wait for their infection to be completely cleared, which is a problem. I told the patient and the family this morning. So I think that's a very important message to have here, is that you need it under control. You don't need it completely eradicated before starting ATG.
Got it. Okay, great point. So, what's your platelet count threshold for when you're giving ATG and after the ATG as well? Do you have any different threshold during the ATG administration?
Yeah. So without ATG, if somebody's, without starting anti-thymocyclobumin, I think 10,000 is a reasonable threshold. That's something we use routinely, and it has served us well. We haven't had any major complications. Remember, the platelet count in these patients are normal. I mean, they're functionally they're normal. They're just not enough number of platelets. Different from MDS or myelodysplastic syndrome, where you might have also a functional defect of these cells like platelets or neutrophils. So without the ATG administration, we usually use 10,000 as a threshold for primary prevention of bleeding. Now, when we're going to start ATG, we like to keep it a little bit higher at about 20, if possible, because some of these patients might be difficult to transfuse because of, they're not, having great increments in their platelet count. But if that's possible, which is usually the case in most places, if you're giving filtered and irradiated platelets or blood products, they should have an increment. They should not be albuminized. So we then go up a little bit higher, and we go up to 20,000, just because ATG can bind to platelets, and then it can bring that count down very quickly. So if you're starting from something like 20 or higher, you will drop to 8,000 or 7,000 the next day or two. But if you're starting from 8,000 or 7,000, that's going to go to less than 5,000 clearly. And that might put patient at a risk of significant bleeding. So again, there's not a lot of literature or data to support what I'm saying. This is just one of these common practices, common sense, it's accepted. But if you have a patient that is difficult to get to 20,000, we've given ATG to patients with 16,000, 15,000, just because patients were not having increment, and it's not a problem as well. So yes, so primary prophylaxis 10, for ATG administration 20,000.
Okay, gotcha. So, I mean, this patient, fungal infection somehow controlled and ATG planned and consented. So, at the point that we are going to administer horse ATG, what is your comment for attenuated dose that was published by Michigan Group and confirmed with MD Anderson?
Yeah, we haven't usually done the attenuated dose. I'm aware of the data of giving attenuated doses of ATG for patients who are too comorbid, older, having a lot of problems, underlying problems. I just don't know if that is actually beneficial in terms of 40 milligrams per kilo for 4 days, which is 160 milligrams per kilo total. So the regular ATG, horse ATG dose is 40 milligrams per kilo times 4, which is 160. Although if you look at the package insert, it still has 20 milligrams per kilo for 8 days, which is a total of 160. But we give it in abbreviated format for a long time, less than 5 days, just to prevent more serum sickness. I haven't done the attenuated dose. If the patient is eligible for ATG, I give it the dose that has been used in most trials in the United States, Europe, and Asia, which is 40 milligrams per kilo times 4 of horse ATG.
Yeah.
I don't know if you give 20, if you're going to alleviate the toxicity, if 20 is better than 40 in terms of side effects. I don't think that has been looked at in a controlled setting. And you might, in theory, be losing probably some efficacy. We don't know. Again, we don't know what the right dose of ATG is. There has never been a dose finding for horse ATG based on safety and efficacy. So it's somewhat historical, and it's given, and it's accepted, and it's adopted, and it's applied, the 40 milligrams per kilo times 4. And we don't know if lower doses is as beneficial, or it's better tolerated in terms of the infusion-related toxicity that can be associated with a animal protein like horse ATG. It can be effective. We know that. I have given lower doses because of real kidney and a lot of issues with toxicity. Very rarely, and patients have responded. So we know that can be effective, but I just know if it's as effective. So I tend to give what we have been doing in clinical trials for the last 20 plus years, 25 years or 30 years almost, which is giving 40 milligrams per kilo times 4. But I can see why somebody might want to give an attenuated dose, thinking that you might attenuate also some of the side effects, the toxicity, improve the tolerability, and hoping that you are retaining the same efficacy.
So yeah, so just to in the lieu of the same question, I mean, when we had the patient, anyway, so what is your really patient phenotype that you will say no for ATG? Like, I understand, debilitating. Do you have any performance status scoring that you use for particularly for ATG administration, or not really?
So it depends. So because I've given ATG to probably several hundreds of patients over the years, I'm pretty comfortable in giving it to patients even up into their 70s and 80s, and I haven't had problems, given the traditional 40 milligrams per kilo times 4 days. So I think it all depends on your experience and your center's experience of giving it this drug. But having said that, I think if you have somebody who's probably going to tolerate very poorly a bad severe infusion reaction, because there's a lot of cardiac problems, they have a very bad performance, or if you just get a sense that they are not going to do well if they have a bad infusion reaction. I would probably think twice. Now ATG, the other thing that is not also established is the infusion rate. It can be given in 4 hours. Some people give it for 6 hours. And I think you can go up to 24 hours. I mean, so ATG can be infused very slowly, and that could really mitigate and attenuate a lot of the side effects that are associated with the infusion of horse ATG. So yes, what I would do is, if I were concerned, I would probably give a slower rate of infusion. But again, not a lot of evidence to support that. But I would probably give a slower rate of infusion with a 40 milligrams per kilo, instead of trying not to give it or giving it a lower dose. Now, which patient do I consider really not eligible for horse ATG? It would have to be somebody who's really, really frail, very frail. Obviously, age usually is associated with frailness, but not only age, and comorbid. Where do I draw the line specifically? I think that's harder to tell you. I would have to see the patient and get a sense and getting a feeling for the patient. And they would have to have quite a bit of frailty and comorbidity, especially cardiac, because those patients actually might have a harder time tolerating any infusion-related reaction. Now, keep in mind that horse ATG is only a modest immunosuppressant. It's not terribly immunosuppressive like alemtuzumab or thymoglobulin or rabbit ATG. So I'm not that concerned in terms of the immunosuppression, but it would just be the infusion-related toxicity, which usually happens in the first day or two, and then that's gone. You might have more trouble, Taha, running into the cyclosporin toxicity due to kidney issues than you might have with ATG. We did a trial, just to finalize, we did a trial which was published earlier this year in Lancet Hematology, which was investigating an ATG-free regimen with cyclosporin plus eltrombopag, and that recruited older patients, frail patients, comorbid patients. More than half the patients had a ECOG performance status of 1. So this was defined by the treating physician. It was not defined by protocol, who these patients would not be considered for ATG. That was left open and subjective. And cyclosporin eltrombopag actually can be effective. It is active. It can be effective. But if you look at the data with horse ATG cyclosporin, or even horse ATG cyclosporin eltrombopag, indirect comparison, because this was a phase 2 one-arm study without a control arm. But if you look at indirectly, it looks like the patients who were treated with cyclosporin eltrombopag alone did not fare as well as those patients who were treated in other cohorts with a horse ATG-based regimen. So I think if you can give horse ATG, the patient is probably better off in getting horse ATG as part of their immunosuppressive regimen, rather than just to give a sort of cyclosporin plus eltrombopag.
Okay, gotcha. Okay, so do you want to elaborate on what is your alternative regimen for unfit ATG patients? Like you mentioned about Campath, but do you have any other? You mentioned about combination of this eltrombopag with cyclosporin.
Yeah. So
Any-
one thing I've seen people do is to for unfit patients. So one thing that and this is part of the conversation I was having this morning. So if you start with one thing I've seen people do is you can start with cyclosporin eltrombopag and see how the patients do, because that's easy to give. I mean, there's the kidney toxicity with cyclosporin. Eltrombopag is very well tolerated. There's some hepatotoxicity that can happen, but that's usually very manageable in the majority of patients. So you can do that and see how the patients do. If you're really, really, really concerned about giving horse ATG, and if they don't do well in the first 2-3 months, you might want to consider giving ATG as an add-on at 3 months. This is actually a trial that's ongoing at the NIH right now. So you can start therapy early, like in this patient, 55. If you don't want to give ATG, you can just kind of start with 2 oral agents and see how the patient does. And if they start getting better in a couple of weeks, then they may want ATG when they're doing better from a clinical perspective. Now, alemtuzumab has been tried. We treated over 100 patients with alemtuzumab in the relapse refractory setting and upfront setting, and we found that it can be active as salvage, 30 to 40% response rate, also in relapse with about 50 to 60% response rate. In the frontline setting, it hasn't really shown to be effective, especially when you compare it to horse ATG. So I would not prioritize alemtuzumab, although it can be an active agent over horse ATG cyclosporin, for example. We did try mycophenolate in 104 patients in combination with horse ATG cyclosporin. It didn't do as well. That was a randomized trial. And we did try mycophenolate, Mofetil. So we did try sirolimus, horse ATG cyclosporin, sirolimus plus horse ATG cyclosporin. That was a randomized trial. So there was an internal control, and that was not better than horse ATG cyclosporin alone when you give horse ATG cyclosporin plus sirolimus, or also known as rapamycin. The mycophenolate trial was a phase 2 trial, uncontrolled, single arm, with 104 patients, and that was not better than what we saw with horse ATG cyclosporin. The rapamycin trial had 42 patients in the horse ATG cyclosporin arm and 35 patients in the horse ATG cyclosporin and rapamycin arm, and that study was discontinued earlier. So that had an internal control. The mycophenolate study was a single arm, 104 patients, and that was not better than giving horse ATG cyclosporin alone. So tacrolimus is something that people have used on the occasion. There's very little data on tacrolimus versus cyclosporin. Some people say that, tacrolimus is better tolerated than cyclosporin. We don't know that as a fact. It's also a calcineurin inhibitor, so it's probably an active agent, but not very well studied. So unfortunately, we don't have a lot of other agents. The eltrombopag is the drug that has been more developed in the last 10 to 12 years in combination with, it started out as a single agent in relapse refractory setting, at a dose of up to 150 milligrams. It had a 40 to 50% response rate. And from 2011, 2012 onwards, it was used in combination with horse ATG, cyclosporin, and eltrombopag in 2 large prospective trials. One American, which was non-controlled at 92 patients, showing that based on historical comparison, it was a better regimen with 3 drugs versus 2. And the European race trial that had about 100 patients in each arm that compared 2 drugs, horse ATG, cyclosporin, versus horse ATG, cyclosporin, eltrombopag, and this arm was better than horse ATG, cyclosporin alone. Now, the other TPO agonist is romiplastin, which has been studied out of Japan and South Korea, and they have shown also romiplastin to be active in aplastic anemia as a single agent, and I know in a relapse refractory setting, usually high doses, up to 10 micrograms per kilo weekly. They're going up to 15 or 20, even higher doses. Now they're using in combination with immunosuppression in earlier lines of therapy. So I just summarized basically everything that has been tried. The quote-unquote new kid on the block are the JAK2 inhibitors, which has been shown in preclinical models to be active in aplastic anemia by abrogating the interferon gamma signaling using the inhibition of the JAK pathway. This is being studied now in humans, and there are some trials, early phase development using anti-interferon gamma products that could also be effective in marrow failure syndromes or aplastic anemia. So this is, in a nutshell, what has been investigated and what is currently being investigated in the setting of aplastic anemia.
Okay. So, so what is your way of prophylacting the serum sicknesses? I mean, we know serum sickness can be a problem after the ATG administration.
Absolutely. Yeah. Steroids. The only reason to give steroids in aplastic anemia is to give it for a serum sickness prophylaxis. There's no role for steroids as therapy in the management of severe aplastic, 0. Now, having said that, we see a lot of patients in Brazil and a lot of patients around the world because we do a lot of opinions that still get steroids. Now, that only adds to comorbidity. The worst infections I've seen in aplastic anemia were patients who got steroids, high dose steroids, before they got ATG or went on to transplant. So it can be very detrimental. So the way we give it for serum sickness prophylaxis, you give 1 milligram per kilo of prednisone. Usually we start the day before. You also give it in the morning of, and then you give it for 10 days, 1 milligram per kilo. Can be given orally. And then after 10 days, if they haven't had any serum sickness, you can do a quick taper from day 10 to day 17, and then you get them off steroids completely by day 17 or 18. And that's how it should be done. You should not continue steroids for longer. You should not give steroids as therapy for aplastic anemia before giving ATG. And the only reason steroids are given is for serum sickness prophylaxis. Now, if somebody had serum sickness and you had to keep on steroids for a little bit longer, or you were tapering the dose and then their serum sickness flared up, then you may want to hold on for a little bit longer. But once the serum sickness is over, you don't need to keep them on it. Once it's over, it's gone. It's not going to come back. So that's the only reason to keep steroids for possibly an extended period of time. But keep in mind that you need to get them off steroids because that's only for serum sickness prophylaxis.
Okay, yeah, great. So now you gave the horse ATG, you started cyclosporin EPA. Now patient obviously started having this problem with gum swelling and nephrotoxicity. So I want you to kind of dichotomize creatinine level above 2, less than 2 and above 2 management for cyclosporin nephrotoxicity.
Yeah. So obviously it's very important to monitor serum levels, trough levels of cyclosporin to make sure that this patient is getting adequate doses of cyclosporin, not too much. So the trough level that has been more widely studied has been between 200 to 400 nanograms per ml or micrograms per liter. And that's a trough level that is very well established. Now, if somebody's having difficulties with cyclosporin and their creatinine is going up higher than 2, I tend to be very permissive in terms of creatinine because patients with aplastic anemia, hundreds and lots of patients, they die of marrow failure. I've never had a patient with aplastic anemia die of renal failure, never. But I had several who died of marrow failure. So you have to prioritize their marrow failure recovery. We had a patient just recently who he was in his late 40s who he got triple therapy, ATG, cyclosporine, trompet, very sensitive to cyclosporin. His creatinine went up to 2, 2.5, and we kept pushing because his marrow had to recover. Otherwise, he would have a lot of complications. Still getting a lot of transfusions, and so I actually let the creatinine go a little bit higher, to 2, up to 2.5 even. I think once he started getting up to 3, I started getting a little bit more concerned. But I tend to go and prioritize. Now, you may want to keep the cyclosporin level a little bit lower if their creatinine is something that is bothering you, and between 100 to 200 is okay. There's data to support that that's also therapeutic level. And if you're really running into trouble, my recommendation would be to give as much cyclosporin as you possibly can. So if you have somebody who's not tolerating, their creatinine goes up to 3 with 150 BID, you stop it, they go down. The creatinine, start at 50 twice a day and see how they go. And if they're doing 1.6, 1.7 creatinine, go to 75. They stay at 1.8, go to 100. They go to 2.1, 2.3. You may want to stop. Give as much as you possibly can, because some cyclosporin is better than no cyclosporin, and that'll just have to be a fine-tuned management of how much you can give. So that's usually how I manage these patients. Usually, I can give some cyclosporin in the majority of patients. It's very rare for me not to be able to give any cyclosporin, and I always try to reach that trough of 2 to 400. If not, I say between 1 and 200.
Okay, got you. So let's say the patient is not tolerating cyclosporin because of some nausea, vomiting, rather than nephrotoxicity. Do you elaborated on this for tacrolimus?
Yeah,
mTOR inhibitors.
I haven't done it. I have not done it. I know that people have done it, and with anecdotal experience saying that, oh, this tacrolimus is better tolerated, or my patient did better, they had less this, less that. So it's not something again, because I can keep my patients on cyclosporin, the vast majority of them, if not all of them. I really had to think about an alternative. Now I have had on the occasion these patients, and I'm remembering now an older patient I had that I treated in 2021, 22. She was very sensitive. She was like in her mid 80s. I mean, she was very sensitive to calcineurin inhibitor, cyclosporin, and she really ran into trouble with her creatinine. So I did, and I had to really not give her or stop it, even the lower doses. But she had other medical problems as well. It wasn't just a cyclosporin. And in that case, I didn't really think about giving her tacrolimus because I didn't think that tacrolimus would be much better tolerated. In that case, I ended up giving her sirolimus, which is a different agent that has not been shown to be effective and given in combination with horse ATD cyclosporin. But in isolation or with no cyclosporin, I think there's some data that suggests that it could be active, especially in preclinical models. So I ended up giving her, sirolimus. I didn't switch to tacrolimus, but I think that some people have experiences and would say that it's a better calcineurin inhibitor to give in terms of tolerability. So I think that's okay. I just don't think it's going to make a huge difference in terms of side effects. But that's something that I don't usually do it.
Okay. So you started the treatment, 6 months passed, and the patient is CR at this point. How do we know if the cyclosporin and Promacta after 6 months?
Yeah, so that's an excellent question. So the trials that investigated eltrombopag or Promacta in the frontline setting stopped eltrombopag by 6 months. If you look at the American trial, the NA trial, it stopped cold turkey at 6 months. If you look at the European race trial, which was a randomized trial where it compared horse AT cyclosporin versus horse AT cyclosporin eltrombopag, it stopped at 6 months, or it could stop at 3 months even if the patient had a CR by 3 months. And if you look at the SOAR trial, which is the one I mentioned, which studied eltrombopag cyclosporin alone without ATG, it stopped eltrombopag at 6 months. So having said that, eltrombopag in the trials have been stopped at 6 months. What I have done is that I have tapered. I know that's not what the trial designs were, but I do a taper. And if somebody's on 150, which they should be, I go to 100 milligrams, and I do that for 2 months or 8 weeks. And if their counts are okay, I go to 50 milligrams for another 2 months. And if their counts are okay, I stop it and watch them for another 2 months. So by 6 months, they should be off eltrombopag. Now that's for eltrombopag. Now that to mention that the trials were designed a little bit differently. So we don't know what's the ideal duration of time of giving eltrombopag. So, and I think 12 months is probably better than 6 months, but that's not been studied. This is based on a hunch. So I do this taper, which is relatively a quick taper of eltrombopag. Now cyclosporin is a little bit different. So when cyclosporin was stopped cold turkey at the NIH trial, there were a lot of relapses at 6 months, after 6 months. And so what was done, it was an amendment to give a lower dose of cyclosporin, 2 milligrams per kilo. And this was based on a prior trial we had designed, where we found that patients who received a dose that was higher than 2 milligrams per kilo relapsed less. So that's decreased to 2 milligrams per kilo, and that's maintained for a period of time up to 2 years and then tapered. The cyclosporin that I do is I usually keep it on cyclosporin, but I start a taper as well, a more gradual taper. And what I have done is I usually go roughly by 25% every 3 months, decreasing the dose of cyclosporin. And I do that up to 1 year. And if they're tolerating the drug well, I usually keep them on that dose for the second year, and then I start tapering them again. So it all depends on the patient's tolerating the medication and how the counts are doing. But in terms of the sequence, I usually try to get them off eltrombopag first and keep them on the tapering doses or low doses of cyclosporin later. So that's how I usually do it. So if they're having kidney problems, Taha, you may want to, I don't usually stop them right away, but I had a patient recently who's having a lot of kidney problems. He reached a 6-month mark on eltrombopag cyclosporin. I inverted. I started tapering the cyclosporin first, and I kept the eltrombopag just because the kidney toxicity. And this patient had underlying kidney problems. So instead of doing the eltrombopag first, I inverted. I started going down the cyclosporin first to give some breathing room to the kidney. And I did that twice. And after I tapered the dose twice, usually 25% dose reduction, daily dose each time. The kidneys got better. I kept the cyclosporin. Then I went back and started tapering the eltrombopag. So it all depends on how the patient is doing. There's no specific rule. I just think that some sort of tapering is important because it gives you a sense of how much of that therapy the patient is requiring. And then you kind of go from there. But that's usually how I do it.
Okay, gotcha. So, I mean, we have a couple more slides. I think 2 more slides, but I just want to a little bit expedite this because we have 3 minutes we'll leave for 5 minutes for question. So, can you briefly say what is this post-ATG antimicrobials recommendations and how you do? Basically?
No routine. Again, no standard of care. What we do, give a cyclovir prophylaxis and PJP prophylaxis. So I give Bactrim 2-3 times a week, double standard, either Monday, Wednesday, Friday, and a cyclovir. I don't usually give primary prophylaxis for antibacterials or antifungals, unless there was a concern for having a fungal infection or unless they had a really bad bacterial infection. But I usually don't keep them on it. I usually treat and stop. For fungus, you may want to keep them for a little bit longer if they're severely neutropenic.
And this is what NIH kind of way of doing
Yes.
antimicrobials.
Yeah, although they use aerosolized pentamidine. But you may want to keep an eye, just to space the Bactrim with the ultramapag if you're going to do that. And if you're going to replace magnesium, as you do with cyclosporin, just make sure you do not replace magnesium with ultramapag, because that will inhibit absorption. So ultramapag, you cannot take any antacids, any of these magnesium or anti-aluminum or whatever, aluminum hydroxide, or cheese or milk derivatives, because that will decrease the absorption of ultramapag. So stay away. My patients usually take magnesium replacement in the morning and afternoon, and they usually take ultramapag at night. So then you don't have any issues with absorption of ultramapag.
The reason that you're using Bactrim instead of the pentamidine, is that because of the resource allocation, or is that
It's practicality,
okay?
and it's a low dose. And usually you can give twice a week, Monday, Thursday, or Tuesday, Friday. You can even give it lower doses. It's practicality, but just don't give it together with ultramapag. Just give it a space.
Okay. So again, you mentioned that my mycophenolate combination or sirolimus combination ATG, but you don't usually use GCSF during the
No.
ATG, right?
There have been 5 prospective randomized trials that studied incorporating GCSF to ATG cyclosporin, and all 5 were negative. So this data, we know that there's no added benefit of giving GCSF routinely in patients with severe aplastic anemia who are being treated with immunosuppressive therapy. 5 prospective randomized trials, negative. So I think that data is correct. Now, if you have a patient with severe neutropenia who's having problems with infections, fever, etc., or you suspect have a fungal infection, giving GCSF for 5, 6, 7 days, it's okay. And if they improve, you may want to keep them on GCSF. But most of the times patients don't improve. And I think just keep giving GCSF. I think it's not something that is recommended. I don't usually give it routinely, but if I'm running into a lot of trouble, I might want to try for a few days. And if there's no response by a week, I just stop it. And then, treat with supportive care. So, yeah.
Okay. How about this new GCSF agent? Do you think is gonna yield any benefit? This usually
Yeah.
or
I think it has to be studied. Again, if you look at the GCSF alone, it's not something that has been shown to be effective. Our newer preparations or different formulations are going to be any different. I think that's something that can be investigated, can be tried. Remember, the level of GCSF in these patients that are endogenous is very, very high. So giving extra GCSF is probably not something that's going to be beneficial. But some patients respond, and you may want to, and again, if you have 50 neutrophils and they go to 150 with GCSF, that's significant, especially if somebody has a fungal infection. So I'm not saying that nobody should ever give it, but when this was done systematically, routinely, prospectively, it was not shown to have any added benefit.
Okay, got you. I think I will end up here, and I'll ask if audience members has any question to ask.
So this is interesting. So what's the role of ultramapag in pediatrics? So when there's 2 things. When subgroup analyses were done based on the NIH trial looking at children, there did not seem to be an improvement of adding ultramapag to horse ATG cyclosporin to pediatric patients. It doesn't mean it didn't have any benefit. No, counts recovered a little bit quicker. I mean, there was some benefit, but when you look at the primary endpoint of having a higher complete and overall response rate, that didn't seem to be better when giving it to pediatric patients. There is a prospective randomized trial that was done out of Russia, which had a total about 100 patients total, which was a direct comparison between the horse ATG cyclosporin plus horse ATG cyclosporin ultramapag, and there was some benefit there in adding ultramapag to cyclosporin, but not the benefit that you have actually seen or observed in the adult population. The population that the better benefits from adding ultramapag to horse ATG cyclosporin is the adult population. Now, is there any benefit in children? We're involved actually currently in a meta-analysis looking at this question, and it looks like there might be actually benefit. that is not being captured by the isolated trials. And this is something that is ongoing, so it's work in progress. So don't quote me on this. So this is still being elaborated, so it's very preliminary. But it looks like that if you look at the data as a whole, it might be that children actually might benefit as well. Now we have to wait for this analysis to become more mature and to wait to see if it really confirms these earlier signs. But so if you look at what has been published so far, it doesn't seem that there is a benefit, but this could change with further studies and further analysis. It is a very interesting question because the pediatricians are left hanging if this is something that would benefit their children as well. So that's something that it is interesting to answer. It's an important question.
I had a question.
So, yeah, go ahead.
Thank you for spending some time with us today. I wanted to know what your approach was to patients with hypocellular MDS. Do you treat them generally like aplastic anemia, and kind of what is there any difference that you would approach these patients?
So thank you for the question. So unless I think that somebody truly has MDS, if they truly have MDS, I would probably treat them as MDS. The question is, how do you really define that somebody has truly MDS? I mean, if they have, a lot of dysplasia, megakaryocyte dysplasia, if you have megaloblastic change, that can happen in aplastic anemia. So some dysplasia can happen in aplastic anemia. But if you have karyotypic abnormalities of micromegakaryocytes, that micromegas should not happen in aplastic anemia. So I would be a little bit hesitant to treat that patient with like we treated plastic anemia if I really felt they had MDS. Now, if I'm in doubt, and it could go either way, I usually give the patient the benefit of the doubt, and I treat him with aplastic anemia type regimens. Because to call a 65-year-old patient with MDS truly MDS, you're talking about giving them MDS type therapy, probably considered transplantation for them. So if I have the doubt that this patient could have MDS, I usually give them the benefit of the doubt, and I treat him with ATG cyclosporin with ultrampag, because these patients can also respond to immunosuppressive therapy, even if they have hypocellular MDS. We have actually investigated immunosuppressive therapy for MDS, and we looked at age, HLA-DR15, transfusion burden, low to intermediate risk MDS, and we've seen that patients do well if they meet those criteria. If they're less than 72, their transfusion burden is relatively low for red cells, and if they have low to intermediate risk MDS. When we looked at the variables that correlated with the response, hypocellular marrow was not one of them. But I know that there's been several trials, others outside of NIH, that have actually looked into this and found that a hypocellular marrow was found to be predictive or correlated with response to IST or immunosuppressive therapy. So if I'm in doubt, I would give him the benefit of the doubt and treat him with as aplastic anemia. But if I'm very convinced that this patient has myelodysplastic syndrome, I would probably be a little bit more hesitant.
And specifically, thank you for that. And the entity, that 13q deletion.
Yeah, I wouldn't worry about that.
You wouldn't treat that any differently than aplastic.
No, I mean 13q, these abnormalities. I mean, the abnormality that would really make me pause would be monosomy 7 or complex cytogenetics. The other stuff, they can be seen in the aplastic anemia. This is just clonal hematopoiesis in a very stressed, destroyed narrow compartment. So these things can appear. Monosomy 7 or complex cytogenetics or increase in blasts or a lot of megakaryocytic dysplasia, which you're not going to see in a very hypocellular marrow. But these things would kind of make me less willing to give them ATG cyclosporin or aplastic anemia type regimen.
Okay, great. Thank you, Brian, for that question. Okay, thank you, Dr. Scheinberg. I mean, I think we covered most of the aplastic supportive care questions that we designed to ask. Again, hopefully we'll keep going talking about this classical hematology cases. And thank you again for your participation.
No, thank you. It's my pleasure, Taha. Great job.
Yes, thank you.